this.
All right, good evening, everyone. Welcome and thank you for tuning in to the fourth Meet the Program Director webinar series. My name is Peter Laskarides. I serve as treasurer at the EPA, and I practice pain at Riverhead at Pain Institute of Long Island. I'm lucky to stay engaged with the residents from my alma mater at Stony Brook and New York Institute of Technology, where I serve as assistant clinical professor. This evening, I'll be moderating our talk with Dr. Yili Wang, who's the Director of Pain Medicine at Phelps Hospital in Westchester, and co-heads the EPA's Program and Education Committee. We're very honored to have our esteemed guest speakers, Dr. Paragi Rana from Beth Israel Deaconess, Dr. Gary Brenner from Massachusetts General, Dr. Kiran Patel from Hofstra Northwell, Dr. Tiffany Lake from University of Vermont. I believe Dr. Issa from Brigham and Women's is trying to get connected, so we'll see if he's successful. But moving on, I want to take a special thank you to today's sponsor from Boston Scientific. They'll be providing some exciting content at the end of today's panel, so I urge everyone to watch. Excuse me. The objective of today's program is to provide some insight and advice to prospective fellowship applicants regarding how to apply during the pandemic and how to best get matched. We're going to have three main sessions: the fellowship application process, secondly, the pain medicine training and optimization, a little brief discussion on that, and then a few minutes also on career planning and the practice of pain medicine in this new era, so to say. So before delving off, I'll ask the panelists individually to take a minute or two to introduce themselves, and if they can please speak briefly on their program. I know a lot of the residents are excited to have you guys, and so are we. So if we could, get started with Dr. Paragi Rana.
Folks, good evening. It's a pleasure being here. Let me start with that. So I currently serve as the program director for the Pain Fellowship here at Beth Israel Deaconess. A little bit about the program. I think it's fairly standard for those of you who are applying. It's a one-year fellowship. We've got subspecialty rotations in palliative care. You spend time on the chronic pain service as an inpatient. And we've got a very diverse group of faculty here. So we get to take care of a diverse group of patients from a lot of different backgrounds.
Fantastic. Dr. Brenner?
Hi, let me see, get some light on the situation. I'd pretty much echo the same things you just heard. I think programs are more similar these days than different compared to the past. We have quite a diverse set of faculty backgrounds, just like everyone. We have people from palliative care on our staff, neurology, physiatry, a bunch of anesthesiologists, psychiatrists, psychology working with us, inpatient, outpatient, a variety of rotations, including palliative care, addiction medicine, physiatry. And I think, if anything, what may distinguish our environment a little bit is we really have a significant number of our faculty involved in major research projects, and that creates a little different perhaps approach. Anyway, that's about all I have to say as way of background. Thank you.
Thank you. Dr. Issa?
Hi, everyone, and so sorry for being a little bit late logging in. So I'm the program director of Brigham and Women's Hospital in Boston. Similar to what Dr. Brenner and Dr. Paragi said, I mean, we are one of the bigger programs in Boston. We accept 10 fellows per year. This year was a little bit of an exception. We actually have an 11th fellow that started off cycle and finishes March of this year, but we typically accept 10 fellows per year. Again, similar to what they said, it's the program is, of a typical pain fellowship program. It's 1 year where you spend time in the outpatient clinic. There's a month or two where you're the outpatient chief, and then there's also a month of inpatient where you go to the main hospital at Brigham, and also you're the inpatient chief during that month. And then there are also some rotations, whether it's in community hospitals at the VA or doing some of the core rotations, including like neurology, working with a psychiatrist. I think one of the strengths and nice things about the program we have is that we have, again, a very diverse faculty from different disciplines. Most of them are, even those from different disciplines, whether it's neurology, psychiatry, they're all board certified in pain medicine. So basically you work with each of these faculty and you're kind of seeing the patients from their perspective, from a pain perspective. It's again, it's a 1 year fellowship, and we welcome everyone from all different disciplines to apply for it. Thank you.
Wonderful, thank you. Dr. Patel?
Hi, how are you? So our pain medicine fellowship is brand new. It's the Hofstra Northwell Pain Medicine Fellowship with the Spine and Pain Institute in New York. I myself started as a private medicine pain practitioner, and our group, the Spine and Pain Institute of New York, is a private practice group. How our fellowship is kind of different is that, if you look at the pedigree of our attendings within our practice, we've all been at academic institutions for our training, whether in our primary specialty or our secondary, especially with our pain medicine fellowships. But we are private practice. And, I think the difference between, the experience with us is that, it's the volume of procedures, and then also the exposure to the conceptual issues of managing and setting up a private practice.
Great, thank you. Dr. Lake?
Hello, everyone. Thank you for having us to kind of represent the University of Vermont. I have been here for about 16 years now. I started out as a fellow and have been teaching fellows for this time period, and have recently taken over the program director role last year. So I'm in my second year of fellows. I think how we differ from many of the other programs talking tonight is that we're a smaller program. We have 2 fellows, a possible third. The third is an unfunded spot, so it kind of goes back and forth as to whether we bring in a third. This is a rough year because of COVID, so we're holding off for this year, but fully plan on probably having another spot and maybe even a fourth. We have recently had a huge influx of need for interventional pain in Vermont, and have almost doubled our staff over the past year. So it's been actually very exciting. We have veterans, people who come here typically don't want to leave. So we have veterans, and now we have a mix of some nice new young staff. So it's been the past 3 to 4 months we've been getting introduced. It's been really fun. We've been doing a lot of new curriculum development as well, adding in lots of workshops, lots of combinations of online and guest and faculty lectures. We have, so my fellowship year, we actually moved into a separate site that is a freestanding site with four fluoro rooms. So our clinic is freestanding with other sites, including obviously the main hospital, an outpatient surgery center, and we have the University of Vermont Medical Center has actually branched out into the network now. And so we have community centers now, or community hospitals that we have started pain clinics there as well. So we're going to be branching the fellows out there as well to get probably a little bit more of a private feel, as well as along with the academics that we have here. We have inpatient, outpatient experiences. We have a lot of palliative care and acute pain service for inpatient, acute and chronic pain service, I should say. We have a program called the Comprehensive Pain Center, which was a branch off of our clinic that was developed a couple of years ago. It's a separate clinic as well across the parking lot from us that really incorporates a lot of integrative health. They have every type of option to patients for a sort of well-rounded approach. They have like a 5-star kitchen. They teach them nutrition, from massage, yoga. They have a yoga studio, psychiatry, psychologist, massage therapies. So that's another thing that we also have organized or combined into our fellowship that goes along well with palliative care and some addiction medicine as well. So a lot of variety and a lot of things happening, and who wouldn't want to spend a year in Vermont?
Fantastic, and thank you, everyone. So now we'll move on to the fellowship application process. I think one of the most important questions seemingly coming from the residents are, what qualities are you looking for in your applicants? And has COVID changed that in any way? So I'm going to leave it a little open-ended. And although I feel a little restricted going one by one for the sake of getting a couple questions across, we'll do that. And then we'll try to open it up and see if we don't talk over each other. So again, the question is, what qualities are you looking for in an applicant? And has COVID changed that in any way? If we could please start with Dr. Rana.
So I think, qualities that we look for in a pain fellow, or I think qualities that I look for in trainees regardless, because I interview for our core program for anesthesia as well, is really looking for those who show a passion for lifelong learning. It's, I think, one of the most important parts of being a physician just in general, but certainly being a physician in pain medicine, where we have really the privilege of working in a specialty that is constantly evolving. I think one of the things, and although this has always been important, one of the things that COVID has done is really bring to the forefront also the importance of physicians, healthcare providers, certainly trainees who can be flexible and be able to pivot in a unique and demanding situation. And I think many in our last application cycle, which we just finished, that was really a wonderful topic to discuss with trainees from a variety of backgrounds who are going in and really providing care in situations and circumstances that were very unusual and highly stressful.
Thank you. Dr. Brenner?
Sure. I wouldn't say that COVID's, I'll get to who we're looking for in a minute, but I don't think COVID's really changed the applicant who we see as, if there's some kind of ideal we're looking to bring on. There's obviously challenges and also, in some ways, some benefits. It's really brought virtual learning to the fore, and naturally you can get outside speakers a lot more readily. So I think that'll broaden our didactic program. Who are we looking for? Basically really self-starters who want to advance the field in the future. And naturally, as you just heard, that includes that by definition are people who are self-learners and lifelong learners, and fellows who are, would really see themselves part as our care team and not in some ways simply as trainees. We really see our fellows as our colleagues. And personally, I'd say I really feel like our patients get better care because of the quality of the fellows who come to the program. I think the biggest challenge with COVID is for the applicants who don't actually get to see the physical program, which is, it's not as important as the people, but I really feel like face-to-face meetings give you a sense of the group in a way that's very hard to discern from video-based interviews. And I'm sure we all hope that by next cycle, this upcoming cycle, we'll be back to face-to-face interviews. That's about all I have to say.
Thank you. And
You're
I agree. I hope that becomes a reality. I think we all must. Dr. Issa, if you can please shed some light.
Yes, thank you, Peter. I mean, I think Dr. Brenner and Dr. White kind of mentioned most of the things I would talk about. Again, talking about how COVID changed, and I'll start with that as well. I'm not sure it really changed much in how we view our applicants. And as you know, this is one of the most sought fellowships in anesthesia, as well as in other specialties. I think, you know, of course, I mean, one of the biggest challenges was with COVID was the application process and kind of interviewing and, you know, scrambling, trying to find a way to shift everything to virtual, which I think we kind of did a good job with it. We developed, you know, one of our fellows was actually, she worked in her previous life before starting medicine as a producer. So she helped us produce the video about the fellowship, which was really excellent. It had a lot of positive feedback, and we played that for our applicants so that they can have a sense of what the fellowship is about and what the program is about. But again, I think that was the biggest change that COVID did, was that it just, you know, exposed us to start thinking of out of the box ways of recruiting our applicants and giving them a good sense of what our fellowship is about. However, looking at the applicant pool itself, you know, I think one of the biggest changes was not COVID, was kind of the introduction of ERAS and, you know, the match a few years ago, where we had like a bigger pool of applicants applying as compared to, you know, the previous years where it was just kind of a few applicants that were really interested in a single program. And this year we had a big pool as well from all different disciplines, and we enjoyed interviewing them. Qualities, you know, we try to continue diversifying our program. Every year we have fellows from different disciplines. I think last year we had at least 3 fellows from non-anesthesia disciplines. We had, you know, 2 from PM&R, 1 from emergency medicine, and every year we try to get at least 2 or 3 from different disciplines. And we try to do that because we see that this not only kind of, you know, completes our fellowship, but it's also very beneficial to our fellows, kind of working together from all these different disciplines, learning from each other. And I always say, you know, one of the best places to learn is actually the fellows room, where they're all sitting together and kind of learning from each other, more than even the lectures and other things that we give them. Of course, like, you know, the previous directors talked about, we always look for people that have high passion for this field, especially that this is a newer field, that we need people that, you know, are interested and have true passion for it to proceed and to succeed and kind of build our field in a better way. You know, those kind of true leaders, those are the ones we look for. Of course, we're kind of also interested in people that have, you know, interest in research. We have a lot of research projects going on, and we try and help them and set their feet to kind of start and go on. And of course, we're always looking for people that, or for applicants that have good rapport with patients, they have good clinical skills, and this is where it's important to kind of talk to, you know, people that work with them and find out how they are in residency and how they get along with each other. Thank you.
Thank you. Dr. Patel?
Hi. So, you know, I don't really think that, you know, COVID has changed what we would look for in an applicant. We're looking for someone who is by far hardworking and is dedicated to the concept of the patient, that is the center of our care, and notwithstanding academic pursuits, but that's the goal of our therapy, is to try to improve somebody's quality of life. So that, first and foremost, somebody who wants to put their nose to the pavement and is a hard worker and understands that by working hard, you're going to learn a lot. By doing more, you're going to learn more. And somebody who is really dedicated to the concept that, the therapies that we are implementing now are probably not going to be the therapies we implement 10 years from now. So it's the idea of learning a skill set that is going to build upon itself. Somebody who is willing to accept feedback and is open to, not so much criticism, but just open to learning. So when they work with different attendings, are open to learning different types of techniques, so that they may make a decision for themselves at some point and say, you know what, I want to do my injections this way. I want to approach my SCS this way. I want to approach my DRG this way. So that's kind of really what we're looking for. Somebody who is going to be this adaptable physician who's going to evolve with technology.
Thank you. And Dr. Lake.
I would echo what Dr. Patel said. I think the number one thing that we really look for is somebody who is very hardworking and really cares about what they're doing, shows, signs of true empathy and true interest in, the specialty of pain medicine. The application process is interesting. We have, as I mentioned before, a very competitive fellowship. And so there's quite a bit of applications that we have to look through. And like for us, we're looking for 2 spots even. And there's, these are 5th-year professionals who are pursuing this. And so many of our applications are just fantastic. So, how do you diversify through this and figure out what, or who might be a good fit for your program? We are our smaller program. We're kind of a family-oriented sort of program, and so we're not a big program. We want to make sure that we can get along for the year and that everybody benefits from this. So, I think letters of recommendation are very important as we're going through applicants to look for those types of qualities in those letters. There's a lot of feedback that you can get from previous fellows will reach out and give us tips or thoughts around people that they may be working with. There's all kinds of things that plays into, who you can invite to actually, to be a part of the interview process. I think COVID significantly changed the interview process. And I think there's positive and negatives. I think that, I was really worried about it because being here and really getting a feel for us as people and the way our setup is as a clinic and the area that we live in is a big plus for us. So them, not being able to be here and get a feel for that, I was really worried about it. So we put a lot into the presentation to start off the interview days, to really try to promote all of that as much as possible. I got really good feedback from the interviewees that it was an important part of the interview because they felt the same concerns and stress of not being able to really experience the places that they were interviewing to get a feel of where they wanted to be. But the interview process itself, I think, went very well. I think, we set up panel interviews, and it was great to be able to kind of interview the all together. And as soon as we were done with the interviews, we got to sort of debrief and review positives and negatives of things that we might think if they were a good fit or not. So it gave us an immediate review, which I think was really nice. I think I would change things if we continue to do virtual next year. We've already made plans to even continue to expand on that. I sent out a small survey and got feedback from the interviewees as well to get an idea of what they liked and what they didn't like and how their process and overall of their kind of interview path, things that they could give us tips on. So it was an interesting and different process, but I do think it's not going to change whether we're going to match or not. I think that it can still be done, and if we have to do it moving forward, I don't think it should be a concern of future applicants.
Thank you. One question regarding the current interview structure, if we could squeeze it in before the second session. A few of our panelists already answered already, but if anyone wants to further clarify, if it's panel or individual one-to-one, in other words, is it similar to what we're doing now with Zoom and having a bunch of attendings interviewing the applicant, or for instance, an individual Zoom or FaceTime call, something like that? And then follow up if you intend to maintain that in any way. I'd like to leave this open and see if anyone wants to jump in rather than go one by one, if you guys would like.
So I didn't comment on this, but our last application cycle, we had a great Zoom series going, but they were one-on-one interviews that lasted for about 12 minutes. And there were virtual signals to let both the faculty member know and the trainee know that, or the applicant know that we were coming up on time markers. You know, at BI for now, the expectation is that all of the interviews will be virtual for the upcoming academic year. That may change depending on what happens, but at the moment, the plan would be to continue virtual interviews using a new platform called Thalamus, which automatically rotates applicants and interviewees through individual waiting rooms and individual interview rooms, but they're still one-on-one at our institution. And we run through about 5 of them. Then with informational sessions with the fellows, where you're putting into a waiting room with our fellows downstairs in our clinic. That's private, that faculty, nobody has access to, so you can ask questions and, you know, get a real feel for what the program is like. We have access to videos that give you information about the main hospital. There's a tour of our building, which I did a voiceover for. That was very weird, but seemed to work out well. So that structure, if we continue virtual, is where we'll remain. But I agree with the other program directors. You know, I think there's something certainly lost in translation there, but we hope that we're able to kind of bridge that gap for the applicants.
Very nice. And Dr. Issa, I'm not sure if you had a question. I saw your video go on and off. If you'd like to chime in before we get moving.
I was just going to comment, and actually we're very similar to BI in our format. So but we used Zoom on our previous application process, and it's kind of like every applicant has a private room. And then we had about 14 applicants per day. So we divided them into 2 sessions, morning and afternoon. We had 7 faculty that interviewed them. And they would move from one room, 6 faculty. They moved from one room to another, and then there's a gap of about 15 to 20 minutes as a break. And during that time, they also get to talk to our current fellows, ask them questions, things like that. And we did it in 2 sessions over 4 days. So we interviewed somewhere around 60 applicants or so last year. I think next year will be very similar unless things change, hopefully, and we can do in person. But I know the residency program is using a different platform this year, and we may also upgrade to that for next year. But Zoom worked really well last year as well, or like this past past few months with the application.
Hi, good evening, everybody. So thank you. And we're going to move on to session 2. Thank you for taking the time to be here. Whatever. So I'm actually in a practice with one of my old fellows, co-fellows, and we often reminisce about the application process and the training process. It's a fast 1 year, but it's incredibly impactful. To that regard, what we'd like to discuss in session 2 is some of the current training in pain medicine and optimization in kind of the new normal. The first question I like to throw out to the panelists is, what advice do you have for incoming fellows? What are some of the most important skills for the fellow to come away with in that short 1 year? Dr. Patel, if you'd like to field that question.
Hi there. So, I think I alluded to this a little bit earlier, which is that, I think the most valuable skill for a pain fellow is humility. You're going to work with a lot of different attendings who are going to have different techniques, and they're going to have different things to offer you. And it's the idea that you're open to learning about how a particular attending does things and why they do it and how they do it, both, in terms of managing patients, in terms of judgment with patients, in terms of, technical skills, in terms of how they do an epidural, a stim, a DRG, a kypho, all of these things. So I think it's really having the humility to just being open and just kind of being a sponge and bringing and being willing to take everything in and then make an assessment and make a decision for where you will land, whether that's in academics or private practice. Really having a sense of, I'm here this year to learn as much as I can from every different attending I work with and take from them, and then kind of absorb and assimilate what I feel personally is going to be the most effective. I mean, that's kind of how I would handle it. And I think that's, certainly our guidance, with our fellows as they work with different attendings within our practice and then with their outside rotations as well.
That's great. I completely agree with that. And Dr. Rana, do you have something to add to that question?
I think that's a really kind of comprehensive viewpoint on this question. And I think actually one of my colleagues mentioned this already, but I think one of the biggest takeaways from Pain Fellowship is not to leave with the expectation that you would have done everything and seen everything, at the end of that year. The idea behind this year is that you have the tools, you have the knowledge, you have the ability or have learned new skills, or skills necessary, I should say, to acquire new knowledge and to assimilate new technologies. One of the things, or one of the parting pieces of advice that I got when I left fellowship was, I'll be pretty upset if you're still practicing pain medicine the way that you were when we first started, like when you were in your training program, because there should be a constant thought process around evolving your own individual practice, which is obviously something that we think about in our board recertifications, but also being able to assimilate new techniques, new technologies, and to be critical of your own practice.
That's great. And it's the idea of perpetually learning. Dr. Lake, do you have something to add?
I would just add, I definitely agree with those thoughts. I think to add to that, to just really fine tune and hone in on the anatomy and the technical ability that you have with the needle itself. The more you really know that anatomy and get confident in what you're doing and how to approach different procedures, then you can expand on that in many different ways and grow and continue to evolve as you go through your next phases of your career, whether that's in academia or as a private physician. So I think those are really important components to the tools of what you do. And obviously that in combination with listening to your patients and just really giving them a moment to make sure that they are on the same page with you and that you are learning how to address them as a person and not just somebody that you're sticking a needle in. Those seem like kind of two different ends of the spectrum with advice, but I think they really do come together to make you a very well-rounded physician.
Thank you. Yes, being well-rounded is key here. A question came in actually, and I think it'll be good for our panelists to kind of speak about how do your programs help fellows who struggle with balancing work, life, family and pursuit of their career. This actually came from our audience. So Dr. Issa, would you mind fielding that question?
Thank you, Yeli. So, I mean, I think that's an excellent question, and it's something that we kind of keep thinking about all the time, not just on a fellowship perspective, but also on an entire institution perspective. And it's, you know, we think about it for all our trainees, whether it's residents, fellows, and even our faculty. And we have several wellness programs that we started years ago and we've been developing, I think with, you know, kind of the start of COVID around March and, you know, kind of going through this whole pandemic, this question has also been amplified, you know, 10 times more, because now we're thinking about not just the, you know, all these different aspects, like social aspects of the fellows and how can they balance all these different things, but also the mental aspect. And, you know, are they emotionally in a good place to kind of continue with this 1 year of, you know, I call it like really intense training. I mean, it's the year that you're putting on different hats. You know, I always tell my fellows, it's the year that you're learning to be an interventionist, a surgeon, a neurologist, a psychiatrist, a physiatrist, all these different hats, and you're trying to grasp all this knowledge within 1 year, add to that all the other aspects. And like I said, I think COVID kind of amplified it because, you know, with our fellows, and a lot of them, they already have families, they have to take care of them, and, you know, the worries about how to balance all of this. And I tell them, you know, you have to set time. So if, for example, you're in clinic and you're working, just put your 100% effort there. And then after that, just forget about everything. Go home, as hard as it can be, kind of, you know, check your emails and do this and do that. Try not to, and kind of put it aside, and just the family time is a family time. You know, it's, again, it's hard even for myself to do this, but I always try to practice it, and I always try to get them a good example, and they've been doing well with that as well. But again, there's a lot of wellness programs that we have that keep developing, and we keep increasing them to kind of help our fellows find ways with, you know, daycare, and find ways with improving their physical health and mental health. And we're lucky to be in an institution that fosters that and keeps growing it, and kind of asking more and more feedback from our trainees so that we can develop more and more of these wellness programs.
Great, thank you for answering that question. And Dr. Brenner, is there anything that you do at Mass General that kind of help find that work-life balance for our fellows?
Yeah, we have a variety of departmental initiatives that help not just our fellows, but trainees in the department with striking that right balance. You know, I have to say, there's a lot to learn in a year, and maybe I'm a little old school. I do think that some sacrifices do need to be made, and this isn't a 9-to-5 job. And I'm not going to be apologetic about that. I think we are looking for trainees who want to get as much as possible out of the year. And that doesn't mean completely neglecting yourself or your family by any means, but it does necessitate two things. One, an understanding that there should be an expectation that it's not an easy year. And secondly, a dedication to your patients and to your craft. And, you know, at the end of the day, it's really just professionalism. You know, and I would say for most of us, it doesn't necessarily get easier when you're done, finished with training. It often gets more challenging. One thing I'd add to what other panelists have said, and I agree with everything, is, and it's related to what I just said, the practice of pain can be challenging for a variety of reasons. There are plenty of patients we may not feel like we help as much as we'd like. We may not understand the etiology of their pain in many cases. And in a lot of ways, there's risk of burnout and toxicity in our field. You know, it's just a fact. And part of what I hope trainees develop a skill set in during their pain year is how to dedicate themselves and work hard and not become toxic or angry at the people they're learning to help or their colleagues because of this. What I would tell you is it's infinitely better than it was a generation ago. And we care about the balance between your work and your personal well-being outside of work, as well as the right balance between your education and service, though I think that's a bit of a misnomer because they're so interrelated as to be inseparable, obviously, except to the extent that someone's just being scudded out. But I would just say that everyone who engages in this fellowship should really expect to work hard. Not obscenely so, but you know, it's not a picnic. That's just a fact. That's all.
Thank you, Dr. Brenner. And I agree. Thinking back, like I said, I practiced with one of my old co-fellows, and it was really fun. But we worked hard, but we had a lot of fun. So, Dr. Rana, I was wondering if, you know, again, we're in this new normal, and I was wondering how has your program changed during COVID, and then what other alternative tools, whether it's telehealth or other things you're utilizing to adapt and improving in your program?
So I think our program has pivoted, probably like many of my colleagues' programs here have pivoted to include telehealth now as a routine part of our care plans for patients, particularly those that are at high risk. So our cancer patients, our elderly patients, you know, our octogenarians, our folks in their 90s. I have a few that are just tipping over 100 at this point. I think actually one of the wonderful things was as we sort of pivoted towards telehealth during the worst of the pandemic a few months ago, we really had the pleasure of working with our fellows in a collaborative environment, trying to understand what are best practices, you know, how do we most effectively and safely conduct a physical exam with a patient whom we are not seeing, you know, verifying that there's somebody in their home, God forbid, if they lost their balance and fell while standing on one leg, do they have a dresser next to them to give them additional balance? So with our class last year, we were able to develop some best practices and continue to work with our faculty group in developing now a curriculum, you know, on how to educate around telehealth, how to use telehealth effectively, how to choose who the right patient is to work via telehealth, because I'm sure as my colleagues may have experienced as well, there are some situations in which it is really not the ideal and probably not the best way to manage patients, if at all possible, to bring them into the office. So telehealth has continued to remain a part of our program. As was mentioned earlier, I think this was Dr. Brenner who mentioned this, it's also really opened up our ability to bring in guest speakers. You know, people are far more comfortable giving lectures over Zoom, and we can pull expertise from a lot of different fields, which has really expanded our didactic program. So it's been actually a wonderful additional tool that we've kind of incorporated over these last 6 months and, you know, plan to continue in the coming years.
Great, thank you for that wonderful answer. And you know, we all have to adapt, and there's a lot of some good coming out of this. So thank you. I think we have time to move on to session 3. I'm going to hand it off back to Dr. Laskaridis for session 3. Peter?
All right. So let's get into the career planning, if we may. I'd like to see if you guys could mention a little bit about any mentorship structure. If if there are any alumni involved geared towards the job search process or that phase of fellowship training. What opportunities and what structure does each program have? If we can get started with Dr. Issa, please.
Thank you, Peter. So one of the things we usually start with our mentorship program is actually once they start the fellowship. So on the first week or so when they start, we actually try and assign each fellow with a mentor faculty. We have a big pool of faculty, about 20 plus faculty in our clinic. And we try and find some kind of synchrony between our fellows who match with us and, what their interests are and how they would fit with certain faculty. And that's where our mentorship starts. We work with them closely on multiple things, if they're interested in staying in academics. And usually what I found over the past several years is that maybe about half of our fellows stay in academic institutions and half go to private practice, plus or minus. We've had a few years where, it kind of went up or down either way. But we try to kind of figure this out early, and then we kind of, assign each of them. And then over the year, as it passes, sometimes we make some adjustments depending on how they do. In addition to that, we, like I said, it's a big program. We have 10 fellows graduating every year. So we have, alumni everywhere, all over the country. And that kind of helps us because over the past couple of years or so, we've actually made a database for all our graduates, or at least as much as we can over the past maybe 15 or 20 years. We have, their emails and contact information, and we'll provide that to the fellows and give them that as an option. If, someone is interested in going to a certain geographical place, they'll reach out to them and say, I'm interested in coming here. Are there any options? What kind of advice you can give me about work here and, open places and things like that. And it works both ways because as we reach out to all these previous fellows, they also kind of think about us and say, okay, you know what, I actually have a position that's open here if you have any fellows that are interested. So this, in the past couple of years or so since we started this, we've actually, I would say like kind of matched, our fellows with some of these previous graduates, and it worked great. Of course, in addition to that, we have other mentorship programs that are sometimes sponsored by, different, let's say, for example, different industrial industries kind of saying, okay, we have these different faculty that do, certain types of stimulators or stuff like that. And we've kind of experimented with it over the past couple of years or so, which kind of worked well in a way in kind of exposing them to more of the private practice and how they can, kind of open up their own practice. And that has worked well as well, in addition to the other things. Thank you.
Thank you. And Dr. Patel, being in New York City, I think a lot of the potential fellows would like to know what type of links your program has, if you could comment.
Sure. So, first I'll start with the training. Being a pain fellow and being a pain physician is not about the number of procedures you do. It's about your judgment. It's about, your regard for safety. It's about your regard for the patient as a whole. That being said, if you go through a fellowship and you do 5 procedures of any sort, compared to doing, say, 20 procedures of any sort, you are going to be more skilled by having experienced 20 than you will if you have experienced 5. I think that's really invaluable. I think, we often refer to the breadth of the patient volume that we have within our offices in New York City kind of as, drinking from a fire hose. because there are a lot of patients, there are a lot of procedures. And with that, you know, you learn, you know, what works, what doesn't work, what patients do well, what patients don't do well, what you know, situations within the history and physical allow you to predict who is going to do well and who is not going to do well. So I think the volume provides an amount of clinical judgment and clinical skills. Now, in terms of how that translates to, you know, links within the community and people's future careers, you know, both myself and Dr. Chapman, who is the founding physician of our practice, you know, we are very much interested in clinical research. And, you know, we're constantly looking at the things that we do and trying to develop clinical studies directed at looking at outcomes and those predictors. So I think that, you know, for our particular program, the breadth of volume that we do, the clinical skills, the judgment skills, and then the clinical research looking at the outcomes, I think that kind of speaks for itself. And in terms of our relationships within the New York City area, you know, we have offices within every borough in New York City, and we have ties to most of the academic institutions and private practices in the area. So I think that for fellows who are interested in private practice, or even academics, or as we say, privatemics, I think that our fellowship program has a lot to offer in terms of mentorship in that realm.
Very exciting. And Dr. Lake, if you can speak briefly on any job search mentorship opportunities and any trends that fellows go towards academics or private practice. I believe, Dr. Lake, are you still with us? I think let's move on to Dr. Rana, please.
So, you know, I think we do probably things that are very similar to a lot of the pain fellowship programs out there. I'm really fortunate we have a very strong GME office backing us within the department. So we keep track of all of our former trainees, in some cases a little aggressively, so we know where they are and what they're doing. We try to keep up to date with their contact information. And, you know, the relationship between the faculty and our fellows, including after graduation, is that it really is a family-oriented environment. You know, as was said before, we think of our trainees as much as they're trainees, they're colleagues, and they continue to be colleagues moving forward. Including sending those text messages and emails, hey, can you take a look at this? You know, I'm planning to do X, Y, and Z. Do you think that's okay? Or, you know, do you have an opinion about this? So that really keeps us in touch with our alumni network as faculty members. I can say even in our class that graduated last year, we had two of our former fellows from that graduated join two of our former fellows in practice, one in California and one in Texas. And they're both doing really well. So that kind of degree of networking that we work on and work, you know, on a yearly basis to maintain relationships, I think is a really effective tool. We're also pretty aggressive in their job placement. So I'll actually be meeting with my fellows in just about 2 weeks or so for their 3-month reviews. And a huge part of that is, let's talk about the future. You know, what's the next step looking like for you? That information is then disseminated to all of our faculty. These individual fellows are looking to move to this part of the country, academic versus private practice, so that we sort of all collectively have our ear to the ground at various meetings of who's looking for individuals to join their practices. And I think that grassroots effort really helps to get our trainees into good positions in which they're going to be comfortable practicing their first year out of training.
Very exciting. And lastly, Dr. Brenner, if you could give your perspective on trends, graduate trends and mentorship opportunities in your program.
Sure. We have 7 fellows. I really believe we have quite a bit of kind of an esprit de corps within the group. We all get to know each other very well. We have tried having a formal mentorship program, but, you know, honestly, I've been running the program for quite a while, and I think that develops quite organically. You know, I'll make in some years offer to kind of create mentors, and generally the fellows aren't especially interested in having help with that, since, like I said, it really just kind of happens pretty quickly on its own. We really have fellows all over the country, and try to the best of our ability, keep track of them. It's not always possible, so that when a trainee has a particular practice type or geographic location they're interested in, we do try to hook them up with a couple people as appropriate. Obviously, we kind of have the hardcore academic institution right here, so people know what that's about. I don't think all trainees understand that it's, as was alluded to, there's a tremendous range. There are private practices that are very interested in doing research. One of our former fellows has his own lab and has developed some new equipment, as you may be aware, Dr. Vallejo. And similarly, there are plenty of academic practices that are eat what you kill. And you really need to know what you're getting into. And the best way is to talk to people who are there. In terms of trends, I'd say the biggest trend over the last 5 years or so, from my perspective, is there are just fewer academic jobs. They're really harder to get. We have people who just have stellar backgrounds, who maybe because they're somewhat inflexible with where they want to go, perhaps not, they really haven't found the academic jobs that fit. And I think overall, many academic departments have become more focused on the business of medicine as reimbursements changed. So I think that's an environment that people applying to pain medicine just need to be aware of. There are plenty of great jobs out there. You just need to know what you're getting into, and not just academics, but the private practice jobs too. You really need, some of these groups are quite unethical, and they hire young people, grind them down, and get new young people. And I have close friends who have been in those kind of jobs. And like everyone said, having a network that you can hook trainees into is probably the most helpful strategy.
Thank you, everyone. It's 6:57. We covered a lot. I want to thank our panelists. It means a great deal to the EPA. We're honored that you took the time to be part of this. Certainly went over many great points and believe we all learned a bit from one another. At this time, I'd like to ask the audience to stay tuned and engaged for an exciting presentation by Boston Scientific regarding spinal cord stim mechanisms of action and their proprietary contour algorithm and combination therapy. So that should be transitioning shortly. Thank you so much, everyone, and good luck to all the incoming fellows and future applicants. Have a good night.
Hi, everyone. Thank you for joining, and thank you for letting us host this evening. My name is Samantha. I am a field engineer for Boston Scientific. So I'm just going to go ahead and share my screen with you today. And we're so excited to have this opportunity to be able to talk with you and be a part of your fellowship programs. One of my favorite things as a field engineer is being able to come out and teach about SpectraWaveWriter and the technology and clinical evidence behind what we do at Boston Scientific. We're going to go over a lot here in a short amount of time. So if you do have any questions at the end of this discussion, you have my contact information. Feel free to send me an email. I'd happy to go into any details of any of the slides that we have today. But I'd like to start off our conversation with kind of where Boston Scientific comes from. This is a very heavy slide. of research. And one of the things unique to Boston Scientific is that we apply this research towards our technology and adapt our technology to what we find throughout our clinical studies versus the other way around. And one of the unique pieces that we see with Boston Scientific and with across all neuromodulation fields is that there are a certain percentage of patients who are non-responders to certain waveforms in spinal cord stimulation, meaning some patients don't respond to subperception, some patients don't respond to paresthesia. And so at Boston Scientific, one of the things that we wanted from a device is to be able to produce multiple therapies in one platform. And that's what Spectra WaveWriter does in spinal cord stimulation. And so what we're going to talk about today is each one of these pillars, a little bit about paresthesia and our different subperception algorithms and things that you'll see throughout your practice in pain management, helping with neuropathic pain patients. So I always like to start these presentations off with the basics of where STIM came from, which is paresthesia. This is that tingling sensation that closes the gate on neuropathic pain. At Boston Scientific, we deliver this very different than any other company out there by the Illumina 3D algorithm. What this algorithm is taking into consideration the electrical properties of the spinal cord, along with the unique lead placement of where your patient needs. And we do this and produce a field shape that's custom to your patients to produce a paresthesia target over the dermatomes and areas that they have pain, which essentially closes the gate on pain. We've used this technology in comparison with an older version of our systems and did the Lumina study to see the differences in using this type of targeting algorithm. What we found is that using Illumina 3D, we actually had 86% of our patients move from the trial to the permanent implant. Of those patients, 42% of them had axial low back pain only. This is a very challenging pain area to cover, and one thing that we pride ourselves on at Boston Scientific is being able to utilize paresthesia and target low back pain for long sustained outcomes. What we found with the Lumina study is these patients maintain therapy out to 2 years with pain scores of less than 3, which is why in our portfolio and platform, we want to maintain this option for our patients moving forward. Now, as we've started to progress in finding new waveforms, Boston Scientific has divided the subperception world in 2 different big buckets. One being our microburst therapy. And as you know, burst is a packet of high frequency pulses followed by a quiescent period. One unique thing of Boston Scientific's platform is having the ability to change the intra and inter burst frequencies. What that means is that we can adjust the amount of pulses within each packet delivered to the cord. We can also adjust how many packets are delivered at a period of time. This versatility gives us the ability to adjust as the pain patterns change, as we learn more about innovation in the field of subperception waveforms, and in possibility with habituation to change up how we're delivering stimulation to the cord. Again, for long-term pain results for your patients. The next bucket is our contour subperception algorithm. And in order to talk about contour, we need to talk a little bit about mechanism of action. So what we know from paresthesia is that we are targeting the dorsal columns. From 1965, we introduced the gate theory, and we know this is how paresthesia works. In recent years, what we found is that subperception mechanisms actually target a different portion of the spinal cord itself. We believe we're modulating the dorsal horn. So one point Boston Scientific wanted to develop was being able to maintain our paresthesia target and also have a subperception algorithm to modulate that dorsal horn. That's when the contour algorithm was developed. This algorithm takes into the unique properties of the spinal cord itself and creates a uniform stimulation field for the patient to cover multiple vertebral bodies with subperception therapy. Now, while we were developing this contour field, Dr. Simon Thompson did a study in relationship to frequency. When subperception came to the market, he asked the question, is 10 kilohertz truly the only waveform that will give you relief in subperception therapies? And what he did was designed a double-blind, multi-center, or double-blind crossover study where he had patients experience 1 kilohertz, 4 kilohertz, 7 kilohertz, and 10 kilohertz. And what he found is across all frequencies, the patients had equivalent pain relief. The significant differences that we saw was that we do have a significant decrease in charge, that patients across from T8 to T11 had different sweet spots, showing the unique anatomy of patients and what they might need. And then 23% of patients responded to only one waveform, either paresthesia or subperception from the study. Again, putting forward why we at Boston Scientific want a platform that can reach as many patients as possible. With the findings from the PROCO study, and with the development of the contour algorithm, which is targeting that dorsal horn better, we continued the question of how low can we go with frequencies to produce a neural dose that isn't overwhelming for your patients, so this can be user-friendly. This is where the HALO study was developed, and they used our contour algorithm and titrated down the dose all the way to 10 hertz. What we found is across frequencies, using our contour algorithm, patients maintained good pain relief. At 200 hertz and 200 microseconds, we found a dip in pain relief scores and a wider variety of responders, which is why currently that's our recommendation in using the subperception algorithm of contour. We also found that utilizing 200 hertz frequency as a subperception option for contour, our patients have 88% less energy usage than 10 kilohertz, making this a much more user-friendly option of subperception therapy for our patients. Now that we've talked about paresthesia and the different subperception options that Boston Scientific have under one platform, the next piece was to combine them in Spectra WaveWriter technology. So what we did was develop a system that could deliver our fast onset paresthesia utilizing our Illumina 3D technology, combining with an option of subperception therapy. Now, not only are we able to reach more patients utilizing the combination of these two programs together, but we actually found an added effect because these are different pathways to the brain. In our recent study, the combo RCT, we found the responder rate increased to 88% with a combination therapy program. That's compared to a 71% responder rate with our single therapy alone. And some of the most profound findings that we've had is in this Oswestry Disability Index, where we dropped 26 points, giving us our patients more mobility and activity throughout their daily lives. And then from there, we found a patient satisfaction rate of 90%. Again, developing our platform to be able to reach the most amount of patients with the lowest amount of pain, and hopefully maintaining their relationship within your practices and with their Boston Scientific reps at the best of its ability. Applying all this technology in Spectra WaveWriter, one device. Does anyone have any questions? Well, again, I want to thank everybody for joining this. Feel free to reach out with any questions amongst our platform of Spectra WaveWriter, of the different technologies and how it's delivered. I hope you guys have all a great evening. And again, thank you for allowing us to host for this fellowship panel. It's always great information that we get from all of you physicians as well.